And welcome to our hot topics today in pediatrics. I'm very pleased to introduce our speaker, but first, just to let you know, we have um, uh, this. We have a sign language interpreter, and this session will be recorded as well. For CME credit, you can text the attendance code 71313. And thank you all for joining us. So Elizabeth, are you teeing up the slides?
I just ran them, so I think we can go ahead.
Okay. So is everybody seeing a view of the slides? I right now see there we go. Okay. So I'm very pleased today to introduce our hot topic speaker, Dr. Jean Raphael, who is a friend and colleague of mine. Dr. Raphael graduated from Williams College and then received his MD degree from Harvard Medical School and an NPH from the Harvard School of Public Health. He completed his pediatric residency at the Boston Combined program and then also completed a Commonwealth Fund Harvard University Fellowship in Minority Health Policy. That led him to advance into his current role as section head for academic general pediatrics, associate professor of pediatrics, and associate vice chair for community health in the Department of Pediatrics at the Baylor College of Medicine in Houston. He's a nationally recognized health services researcher with a focus on improving systems of care to benefit underserved and minority children, particularly those with chronic conditions. He's received funding nationally from the NIH, from the Patient-Centered Outcomes Research Institute, and from HRSA. He serves as an associate editor for the journal Academic Pediatrics, and his research is complemented by policy efforts towards improving the care of vulnerable populations. He is the founding director of the Center for Child Health Policy and Advocacy at Texas Children's, and I got to know Dr. Raphael in our at a national level, as he and I were both on the board of directors for the Academic Pediatric Association. Dr. Raphael serves as the chair of the Public Policy and Advocacy Committee for the APA. He's a past appointee of the Lieutenant Governor to the Texas Health Disparities Task Force, and his awards have included the Research Mentorship Award from the Department of Pediatrics at Baylor, a Health Advocacy Award from Doctors for Change, and Meritorious Service Award from the Texas Health and Human Services Commission. He currently is a practicing primary care provider in the Houston area caring for vulnerable children. So thanks so much for joining us today from Houston, Texas, Dr. Raphael.
All right, thank you. It's really great to join you all in Maine. And so actually Maine was supposed to be my summer vacation with my kids. We meant to go last year when we went home to visit family in Boston. We didn't make it, so this was supposed to be the year, but I will take it virtually. So today I want to talk to you about health inequities, racism, and bias. And I put this title in there, Moving from Pensive Statements to Transformative Strategies, because I think we're all in this moment where we've been inundated with all this information, evidence of social injustice, and we're all trying to figure out what to do. And we're trying to get to that point, from that point of what we're thinking about to actually action steps. So that's the goal of today. So in terms of disclosures, I have nothing to disclose. And so here we are in the last few months. You know, we started off in March with this incredible pandemic of coronavirus. And then we were dealing with that. And then all these disparities started to become evident in terms of how racial ethnic minorities were doing relative to other populations. So more morbidity, more mortality with respect to COVID. And then you had the killing of George Floyd. You had a number of other killings that became public at that time. And again, these were things that weren't new. It was just all within this concentrated context of the pandemic, where you just had a tension of our society in a way that you just haven't had before. And so it just kind of left us with all these very strong images and sort of this wonder of how do we address what's going on? And so if you look at all these journals in the last few months, you can see all these statements about racism, about impact of racism on child health and adolescent health from the AAP just last year, how to create change at academic centers, time for listening, Black Lives Matter. And I don't know about you, but after a while, you start to read all of these, you agree, but you feel inundated, and you don't feel necessarily a sense of what you can do or how you should do it. So to me, it always becomes that question of, I hear it, I see it, but what do I do tomorrow? How do I meaningfully contribute to this conversation? And so what I really want to do today is to really just kind of go through some of the data that we have and not just go over the same old information, but just try to think about it in a different way and sort of come up with some ways that we can think about next steps for how we can actually contribute as a healthcare system and society. So the objectives for today are 4, which seem a lot like to me, but I want to give you a little bit of an overview, a brief one on health inequities, summarize the research on bias in healthcare, talk about the role of racism in health and healthcare, and then review the state of diversity in healthcare, which is very much related. So let's first talk about health inequities. So this is something we know a lot about, but I just try to put it in simple terms because I think that's how it helps me process what it all actually means. So there are all these words that we talk about. There are disparities, there are inequalities, there are inequities. So how do they relate to each other? So this is how I think of a health disparity, and I think about it in 2 different terms. So there is inequality, which is where you think about a difference in condition or rank. And so you can say the prevalence of breast cancer and people who are in this country are very different from people in another country. And there's no social context to it. You're really just describing a condition in rank, difference in condition or rank. But then when you add social context, and now you say something is an equity, you're saying here's a difference in condition and rank, but there's something fundamentally about it that's unfair, it's unjust, it's unnecessary, and potentially unavoidable. So it's that sense that now you've layered on social context and how all those things really impact what's going on and the difference that you see. So that's how I think about disparity. And then who's vulnerable to disparities? So historically, we've also always thought about racial ethnic minorities. So specifically African Americans, Hispanics, those particular populations. But there are also other ways to think about who is vulnerable. So it could be socioeconomic status. And sometimes when you do analysis of studies on disparities, you see that if you actually incorporate socioeconomic status, that a lot of the disparities may go away. They don't disappear, but socioeconomic status definitely has some impact. There are also rural disparities. So if you look across the United States, just one example is the opioid epidemic. And you see those individuals and children and families in rural areas are much more strongly impacted than in other populations. So rural disparities is something that has really gotten more attention in the last few years, deservedly so. And then we also have newer populations. So think about all that we talk about in terms of immigrants. There's sexual orientation, there are stigmatizing conditions. So one primary example would be sickle cell disease, where you have layering of a chronic condition that specifically affects or impacts minority populations, specifically African Americans. And then you also have this condition which predominantly is about pain. So then you have all the stereotypes that you may have about this condition of sickle cell disease and people having pain and people seeking out drugs. So it sort of combines in a very adverse way for this population. So those are some of the individuals who are vulnerable to disparities. And then when we think about how they get propagated in the healthcare system, there are a number of different mechanisms or multiple levels. So one, you can think about it at the patient level. It may mean that when a patient comes into the healthcare system, they may have certain health beliefs or health literacy that already bringing into that healthcare system already put them at a disadvantage with respect to disparities. It could be through the provider. Provider may have biases against patients or certain stereotypes about different populations that also kind of come into the mix when you have them come together in a clinical encounter. And then I put here the clinical encounter itself can be something that propagates disparities in the sense that you may have the patient feeling one way towards the provider, have a preset notion about the provider, and the same thing with the provider. So then they play off of each other. So if I'm the provider and I see this patient from a specific population, I say, well, my stereotype of this population is that they're historically stoic, they don't really engage, they don't talk to you. So now as a provider, I change my behavior based on my stereotype of that population. So now I'm much more withdrawn. I try to go through things quickly. I don't go in depth about a lot of things based on those stereotypes. And then that patient even gets more withdrawn. So it becomes this self-fulfilling prophecy within the way they interact. So health communication is a big factor there. And then there are all these other factors within the healthcare system that really sort of impact how disparities are seen and manifested. So I want to talk a little bit about Maine, because I think sometimes when people talk about Maine, Portland, other cities throughout New England, there is this tendency to say, well, disparities, racism, bias, not really relevant here. Look at our demographics. So on the left-hand side, you have child population by race in 2018 within the United States, and you can see the diversity there. And then you look at Maine on the right-hand side, and you see much less diversity. So where if we just look at non-Hispanic whites alone, in the United States, it's about 50%. In Maine, it is about 88%. So there's this natural tendency to say, well, Maine is naturally, predominantly homogeneous, so why do we care at all? But I think then when you start to dig a little bit deeper, you go to specific categories. So for example, here, looking at poverty, you do see that it becomes important, because now when we look at poverty and we look at non-Hispanic white, it's about 16.6. When we look at African Americans, it's 45.6. So now when you've narrowed it down to children who are living in poverty, you do see disparities. So it is much more relevant. Another thing that I think, particularly in Maine, is that you could see differences in language. So having a number of refugee populations and people who are racial ethnic minorities but happen to come from other countries, you could see just looking at different parts from cities and areas and counties that in some places, yes, English is just about 98%, but then there are other places like closer to Portland where it's closer to 90%. So again, predominantly English is the language, but there are these areas and specific pockets where there is some diversity with respect to language. So all is that to say is that it absolutely in every way is relevant for Maine and for other places in New England. So let's talk a little bit about what we know about disparities in healthcare. And I don't want to go in depth into tons of them, but just broad strokes. And so here are some major points. So one is just that people of color encounter disparities in access to care, quality of care, health outcomes. So we see it with respect to diabetes, asthma, heart disease, cancer, specifically colon cancer. And then when you start to look at sort of how people interact with the healthcare system, we know that people of color are generally less satisfied with interactions with their healthcare providers. That's in general. It also occurs along the lines of subspecialty care as well. And then when you look at just sort of more of the interactions, what really sort of shapes and reflects what it looks like as a person of color in terms of their interactions with their providers, when people do the studies around health communications, what they find is you tend to find more dominant communication styles, fewer positive emotions from the provider. The providers often don't ask for input, and just overall less patient-centered care. And they've done these studies in pediatrics where they've actually looked at the amount of time providers spend with racial ethnic minorities in primary care. And the numbers show that even if you look at it by minutes, it's much less time relative to when you have doctors taking care of white children. So the disparities are there, and they've been documented just as a whole. And so I wanted to kind of think about this starting off through the lens of social determinants of health. I think today that's how we typically tend to think about disparities, health inequities, because you're thinking about the places people live, they work, they play, education, and all of that. And I think this is a study that really kind of highlights how all those social determinants come together, but also highlights how disparities as a field is so messy in terms of thinking about what causes what. So this was a study in 2013 where the goal was to really look at disparities in the use of hospitals for major surgery. And so what they really want to look at is very simply, let's look at white patients, Black patients, and let's look at the differences in people who have surgery in what we deem low quality hospitals versus high quality hospitals. And they're also looking to see whether geographic proximity to low versus high quality hospitals explained any differences. So the data source were Medicare files. So these are all individuals 65 and older who all had Medicare. So in theory, these individuals all had the same access to care. And I say in theory because with all the different nuances and, you know, some specific differences, that's not necessarily going to be the case. But overall, somewhat, you know, uniform access to care. So these are individuals 65 and older undergoing a number of surgical procedures, coronary artery bypass grafting, abdominal aortic aneurysm, and resection for lung cancer. So the variables they looked at was hospital quality, and hospital quality was determined by a number of variables in terms of just looking at mortality, looking at morbidity after surgery. So they were able to come up with an index for what determined hospital quality. And then very simply, they just looked at geographic proximity from where the patient lived to the hospital. And then they also looked at racial segregation. And the analysis was logistic regression. So here's what they found. They found that Blacks were more likely to have surgery at what were deemed low quality hospitals, again, based on morbidity and mortality. And they were less likely to have surgery at high quality hospitals. And what was really crazy to me is that if you looked at it, Blacks actually lived closer to high quality hospitals. So, you know, and I just want to focus on that result here, because it's so confusing and was jarring to me the first time I read the story in the sense of, okay, why would I go to a low quality hospital if I live closer to a high quality hospital? And so it's really complicated. And so as you know, as I'm talking, I want you to also think about some of the reasons as I go through mine. I think there are a number of reasons that sort of explain this. I think one is, you know, just in general, how do we all know what is a high quality hospital versus a low quality hospital? You know, sometimes there is information where you can go to specific, you know, journals or publications to find out for specific procedures, but not everyone knows that those exist and not everyone has access to those publications. So that's one. So there may be sort of a difference in terms of having access to the information to even know what's low quality versus high quality. I think another issue is it may be referral source. So it may be that your primary care provider just happens to refer for surgical procedures to specific hospitals, which end up being, you know, what are deemed low quality hospitals. So it really could depend on, you know, the referral source and area of your primary care provider. So that's another factor. Another one where I think it really kind of gets into these issues of bias, potentially racism, and all of those factors is it may be that, you know, you've gone to the quote high quality hospital, and when you go to the high quality hospital, you don't necessarily feel accepted, you don't necessarily feel comfortable, and just and the way you feel there. And it may also be the experiences of your community and how they've been treated going to that quote high quality hospital. So for you, in essence, that hospital may not be high quality for those reasons in terms of how patient-centered it is for you. So perhaps going to what are deemed low quality hospitals may actually be a higher quality hospital to you because you go there, you feel comfortable, it's representative of the community that you come from and the people there look like you. And so those factors may play in as well. And another thing I will add in is that it may also mean that the services that you need, particularly as a patient, exist in those quote, low quality hospitals versus the high quality hospitals. And the services that I'm talking about may either be social, you know, maybe things like social work. It may be interpreter services, whereas, you know, at the quote high quality hospital, there may be a few interpreters, whereas, you know, at the low quality hospital, there are tons of interpreters. So I think all these factors come into play when you think about historical experiences of these patients at certain hospitals versus others. It could be the experiences of their communities in these hospitals versus others. It could also be the types of services, again, that you get at one hospital versus another. And so I think it's bias that you can find along different levels. It can be in terms of how you felt in these places. It can be in what services exist. And it can also be just the limitations of what your provider is able to, where your provider is able to send you and where you live in terms of the even access to the providers that you have to be even able to get to some of these hospitals. So again, my main takeaway point is that this is pretty complicated when you think about it. And so I want to use that as an introduction to really start to think about, bias in healthcare. So there are three types of bias in healthcare that I think about. So explicit bias, I'll start off here, is probably what we typically think of, in terms of something that's much more concrete. And so it's where, someone has attitudes or stereotypes of particular individuals or groups, and they're really conscious of those. And so they know it, they feel it, they can articulate it. And then there's implicit bias, which is here you have these attitudes or stereotypes that could impact your understanding, your actions, your decisions, but it's in an unconscious manner. You're actually not aware of it. It's built up over a whole lifetime. And it's just all these experiences from childhood, and sometimes these biases we have, they get confirmed by experiences we have with these groups, and it becomes more solidified. And over time, it becomes much more concrete for you, where again, you're not even thinking about it. It just goes right into action when you interact with these groups or when you think about these groups. And I think the important thing to really relay about implicit bias is that it truly represents a normal component of social cognitive processing. So sometimes I feel like when we start to talk about implicit bias as a group, people get really uncomfortable because there's sort of this sense of like, oh my gosh, what does this mean about me as a person? And it actually means you're normal. It means that your cognitive function works as it's meant to work, but there's more work to be done to sort of undo some of these implicit biases. So, when we think about implicit biases and when they get worse in healthcare, there are a number of places where they get worse. They particularly get worse when we're in these modes where we're trying to think quickly, where we're in stressed environments or competing demands or maybe overcrowding. So think about being an emergency care department or an ICU. And it doesn't mean they don't happen in other settings within the healthcare system. They absolutely do, but they're even more stressed in these systems because when providers start to feel this distress of, oh wow, I'm backed up with 5 patients, this patient came in here for this and this one here, then you start to rely on those heuristics and those cognitive shortcuts, because that's helping you get through things faster because you don't have to think as much, you don't have to process it as much. It allows you to multitask, but the downside or the adverse impact is then those stereotypes start to get heightened in a way that they shouldn't. And that's been definitely demonstrated in the literature. And what's helped us a lot from a research standpoint in terms of thinking about implicit bias is this mechanism called the implicit association test. So this was developed at Harvard a long time ago, and it's this established measure of implicit bias where it looks at your response time in categorizing pictures of various racial groups. It could be around gender, actually, sexual orientation, physical appearance, and it sort of has you keep hitting these keys, and you're supposed to do it in quick time, so you can't really think through what you're you can't think through what is this socially acceptable response. So you're trying to associate these concepts of good or bad, positive, negative, and look at different types of groups as well. And so it truly bypasses your ability to sort of give the socially desirable response, or it really gets at your implicit thoughts. And what's been interesting about this literature, and there's a lot of it out there now, is it demonstrates that health professionals exhibit the same levels of implicit bias as the general population. So while we think we all go into this noble profession as physicians, nurses, social workers, all different types of healthcare workers, that we absolutely in every way have the same biases, implicit biases, as the general population. And what's even more concerning about some of this data and research around implicit bias in healthcare is that there's an inverse relationship between implicit bias and quality of care. So as your implicit biases increase, the quality of care received by the patient actually decreases. So that is pretty concerning. And so now it's to the point where there have been multiple systematic reviews that actually demonstrate this. So what I want to do at this point is just go through some of the key studies in the literature to think about disparities, to think about bias and all of that. And so the first study I want to talk about is what people call the Shulman study. So this is a study that came out in 1999, and it's this really seminal study in the health disparities field, specifically looking at bias. So what they wanted to do was look at physician referrals for cardiac catheterization based on different case vignettes. And specifically, they were just looking at Black versus white actors. So they went to these 2 professional conferences for physicians. And what they did is they had these physicians look at these different scenarios. And what they did is they just altered the race, ethnicity, and gender of these patients. So you're given a picture of what the patient looked like. You see them here, and then you see them here. And then again, they just played with gender, age, race, ethnicity. So there are very limited number of variables at play. And so the idea is that with that understanding, that the outcomes would really, you could really focus on what is happening with respect to race, age, and gender. And so they gave these physicians these scenarios. You had to rate what the chances of them having, heart disease, and then you had to make a decision about what to be done and referral for cardiac catheterization. And so they looked at, their analysis in a couple ways. I'm not going to get into all the details of it, but in one way, they looked at the independent influences of race and sex. And so you could say something about race and you could say something about sex separately. But then they also looked at these interaction terms, meaning that they coupled race and sex together such that you could look at white male, black male, white female, black female, and sort of put it all together to really get a much more drilled down version of what disparities could look like. And here's what they found. They found that when you looked at it, there were these disparities specifically around Black females in terms of them being less likely to be referred for cardiac catheterization. But at that time, it was really controversial what was found, because as it got played out in the media, it was, there are all these disparities with respect to race and respect to gender. And there were a lot of media reports about it. And then there became this conversation within the journal, New England Journal, about this. And so here are just some of the quotes here. We were surprised by the conclusion of Shulman et al. That race and sex of a patient independently influence how physicians manage chest pain. Their data do not support this. The results presented in Table 5 of their article clearly show that with the use of white men as the reference group, only Black women were significantly less likely to be referred for cardiac catheterization. What I found fascinating about this discussion is disparities were still found. There is evidence, but people were talking about, well, it's not as bad as how it looked. It's really just Black women. And again, you see the other comments here. And here was the final editor response from this. It says, "We take responsibility for the media's overinterpretation of the article by Shulman and colleagues. We should not have allowed the use of odds ratios." So there's all this debate about, how they reported their outcomes as well. And it says, "Although racism and sexism are prevalent in American life, the evidence of racism and sexism in this study was overstated." So true in academic argument, academic discourse, this is actually what we want. But at the end of the day, I still look at it as there were these disparities, particularly for African-American women. So again, it makes you think, what's going on that when we have these limited number of variables there, and it's a clinical vignette, so we've really controlled for a lot that African-American women aren't being referred for cardiac catheterization when it's something that's warranted. So again, making us think about what kind of biases are at play among health professionals. So now we're going to move on to another study. So this was another research study looking at just physician bias. So the goal here was to look at physician preferences and stereotypes that were affecting clinical decision-making. And a lot of times these studies, I think, to keep things simple, just do white and Black. They don't include Hispanics per se. So the subjects in this study were now emergency residents in 4 major academic medical centers. And so they used a web-based instrument where they randomly assigned participants to look at a clinical vignette, and they had a picture. So this patient was either white or they were Black. And so they had the vignette, small number of variables again, and it was a 15-year-old male presenting with chest pain in the ER. And so what the participants had to do, that say, well, here's the likelihood of coronary artery disease, whether they would give thrombolysis or not. And that was sort of standard care at the time. And the other variables they tried to assess were just explicit biases. So these were just questions to the subjects about their racial preferences. And then they also used the implicit association test to really get a sense of implicit bias. So in this study, we're looking at this clinical vignette. Are you giving thrombolysis or not? What's your explicit bias? And then we're also getting at your implicit bias. So here's just sort of example of what the implicit association test looks like. And again, you're just given these keys that you're supposed to hit based on the words that you see, the images that you see, And again, it sort of bypasses your ability to give the socially desirable response. So what did they find? They found that physicians, surprise, surprise, reported no explicit bias. But when they looked at implicit bias, it showed that physicians actually had implicit bias favoring whites, and they had implicit stereotypes of blacks. And as their implicit bias favoring whites increased, so did the likelihood of them treating whites and not blacks with thrombolysis. So again, another study now using the implicit associations test and clinical vignettes in a limited number of variables documenting some sense of bias. And it's hard to get out of that, because again, you can't say, well, there's these other things. You should have looked at hospital type. You should have looked at this. We actually have controlled for all of that. So it does confirm that there's something in the milieu in terms of how, we as physicians actually approach our patients. Again, not necessarily in an explicit way, but an implicit way. So I think the question that started to arise in the last few years is, are children actually immune from this type of bias in healthcare? Because all these studies have predominantly looked at adults. So maybe children are safe from this. And so there have been some studies that actually look at this, and those studies actually show that there is potential that there's bias in pediatrics as well. So these are a couple of studies that have been done where they found that children are less likely to receive opioids and experience optimal pain reduction for fractures. And this study just came out in Pediatrics in the last year. And then there have been other studies that shown their disparities with respect to racial ethnic minority children and being given analgesic management for acute abdominal pain and also appendicitis. So they're less likely to receive medication at all, and they're also less likely to actually receive the appropriate amount of medication. So absolutely in every way, we're starting to see this bias in pediatrics. And I think the next question is, how much can we sort of put it on potential bias? And so there are studies actually also addressing this as well. So this was a study, the first study was looking at potential implicit bias towards American Indian children. And so what these researchers did was they adapted the implicit association test to actually incorporate children for the first time. And so they looked at ER physicians in 5 centers, and they found that 84% of those providers had implicit preference for non-Hispanic white children or adults compared to those who are American Indian. So very clearly looking at, again, a population that we often don't think about in American Indian children, that there is bias against those children, not just adults, against those children. And then there is also another study which looked at residents, and it showed that residents had implicit racial bias against African-American children, and that was pretty similar to what was being seen against African-American adults. So now we do have this sort of emerging literature that is showing that there is bias against children as well. So we can't just say, well, it's just against adults, we're pediatricians, we would never do that, we're different. Again, as the research has shown, we are in every way representative of the general population in terms of our implicit bias. And, whether it's adults or children, we also have these biases as well. So then the question becomes, we've presented all this data on bias in healthcare, implicit bias, the IAT. Yes, we've controlled for variables. So what do we do about it? And, it comes very simply down to really confronting our explicit and implicit bias and just recognizing, again, as a starting point, that implicit bias is a normal, yet importantly to state, malleable part of human cognition. And again, I think the problem is sometimes we don't start there. We start by feeling guilty. We start by feeling bad. And then it makes us not even able to actually engage in the conversation or discussion of what we could do to actually get better. Because fundamentally, if I think I have bias, I think of myself as a bad person. And then what does that really mean about me? But if we reframe how we think about this in an honest way and truly understanding it's not a normal part of cognition, that gives us a much better starting point to actually act. And so some of the promising strategies that different researchers are putting out there, and I think we're still accumulating the evidence base for, is the ones below. So one is just stereotype replacement. So, and all of this requires a lot of self-reflection on the part of us as providers. So one is just really trying to replace the stereotypes we have about specific groups with, other ways to think about them in more of an honest way. And then counter stereotype imaging may be where you look at a particular person from a group and you realize you have a stereotype of them, and then trying to think about another way to think about that particular group. And then individuation is really what it sounds like, is really trying to look at each person as an individual and trying to not immediately add that social context around them. And then perspective taking. So when we're interacting with patients and we see that they've acted in this way that really confirms this bias that we have about this population, starting to think about, well, you know what, they came to, the ER for this concern. Oh my gosh, this group always comes in for this. It's just who they are. I've seen it over and over again. Stopping yourself in that moment and thinking, you know what, but, here in this situation, I know this family kind of went through all this other stuff. They don't have the right insurance. They live far away from care. And, the parent works 2 jobs. So I can see in this situation, from their perspective, why they would be doing this. So really, again, just taking a deeper look at what their perspective is, looking at the individual cases, trying to counterbalance sort of your innate biases against different groups. And again, to be able to do that, you have to become aware of what these biases are. So it's a lot of training around implicit bias, and it's, taking yourself and allowing yourself to do the implicit association test, which, having done it several times, can be a little painful because you discover things and thoughts and biases that you didn't think you had. And I definitely include myself in that area. And the last thing is really just partnership building between the provider and patient. So really starting to ask and engage and ask the really good questions about what's going on, why did they come in, what are the things that are impacting how they're actually engaging in care. So these are the strategies people are really trying to do more research on in terms of coming up with implicit bias training, having people examine their biases, so all in combination with doing the IATs. So this is a starting point, and I think in the last few months I've seen a lot more institutions start to move themselves towards implicit bias training. So sometimes that's a matter of bringing in outside experts, or really starting to think about how you can do it yourself as a group over time with the experts that you do have. Oops. And so the next thing I want to talk about is racism in health and healthcare. So we've talked about, bias, specifically about implicit bias, but then there's sort of that more stark version of what can go on in healthcare. And these 3 images we'll kind of go through in a little bit. And when we think about racism, I think Kamara Jones, who is an epidemiologist who's well known for her work on racism, really puts it into these 3 different categories. So one is internalized, second is interpersonal, and third is institutionalized. So I think the one we predominantly think of is what is known as interpersonal. So thinking about someone having a prejudice and discriminating against another group. Again, that's the one that we know really well. I think the next one that's really important that we're really having this conversation about now over the last few months is institutionalized racism. So that is differential access to goods, to services, and opportunities by race. And so some examples in society, one is just redlining. So when you think about historically how neighborhoods have thought about, and how historically, different people and policymakers would draw a red line around certain neighborhoods, and sort of those were the neighborhoods not to invest in. And predominantly those neighborhoods ended up being ones with minorities, with African Americans or Hispanics. And those would be the neighborhoods that didn't get a lot of investment. So grocery stores didn't come there. Other types of opportunities didn't come there, just again, based on race. And that's something that's institutionalized, because then it's done at this broad level, but then it affects access to healthcare, it affects access to, to food and groceries and everything else, built environment, parks, all of those things that really help people live their lives. So it sort of is this negative harbinger in terms of social determinants of health. So that's a difficult one to attack, because it's so ingrained and hardwired into our society that we really sometimes don't even think about it. It's just sort of as you go every day, you're like, oh, of course, this is what this neighborhood looks like, because that's what it is. But when you think about it, there are all these policies behind it that need to be addressed. Internalized racism is another area that I don't think a lot of us think about, but it's essentially it's acceptance by members of the stigmatized race of the negative images around their own abilities and their intrinsic work. So if I'm African American, I see all these stereotypes of what African Americans are and who they are. I start to believe them myself, and I start to act in ways of, I get afraid when I see an African American, or I start to think about these things, or I even think about these things about myself. And so a specific example is there's this literature around a concept called stereotype threat. And that concept, some of you may be familiar with it, it's where you sort of act like the stereotype of your group. And they've done all these studies around it, which is fascinating. So an example would be if you're about to have an exam in a college setting and you make some subtle statement that, for example, for women, you say, women tend not to do as well on these exams, or just very subtle comment that when you look at those scores, you can see that there is an impact versus when you don't say anything at all. Or you may say something about, Hispanics tend not to do well on, these types of tests. And then you have the test and you'll find that that group performs to what you've said. So it can be activated. And so I think this is a very dangerous and concerning type of racism because, again, you don't know walking around that you even have that. It's just internalized and you act towards that stereotype sometime, especially with respect to test taking performance when you're reminded or when it's primed. So again, I want you all to think about these different types of racism because I think we always focus on the interpersonal, but these other ones are actually really, really damaging. And they're the ones that are harder to get at because they're not the ones that sort of are obvious to us. And in healthcare, there are all these examples, historic examples of racism, which I find fascinating because I love the history, looking at the history of medicine. And so one is just the Flexner Report that came out in 1910. And this was this report that really, where all this work and research was done about what made a good medical center in terms of medical education. And it was trying to find the ideal setting. And so this person, I believe the first name was Abraham Flexner, went out and visited all these medical schools. And what his ideal was Johns Hopkins University. That was the essence of what biomedical education looked like. And then he also determined the traits and characteristics of different types of med schools that should be closed, that weren't representative of what was going on at Johns Hopkins. And at the time, in the early 1900s, there were actually a good number of medical schools that were predominantly African American. And he went and looked at those schools and he said, you know what, these schools are inferior. Here are all the issues with them. And his recommendations resulted in the closing of 5 out of 7 of those medical schools. And so that's something when you think about diversity in medicine, something that's had such long-term consequences from, again, sort of that bias in terms of looking at what makes a good medical institution or medical school versus not. And he specifically reports on, has a section on these Black medical schools. The second example is something that I think we're all pretty familiar with, is the Tuskegee syphilis experiment that started, I believe, in 1932, went all the way to the early 1970s, where scientists were looking at the natural history of untreated syphilis in African American males. And during the time period of the study, penicillin came out as the definitive treatment of syphilis, but the scientists continued for another, I think, 30-something years, even with the existence of penicillin as a definitive treatment. It wasn't until the 70s they actually stopped the experiments. And so that's, one of these classic bioethical examples of what can go on in terms of race, ethnicity, and racism in medicine, in research that is often cited. The last one I want to talk about is one that I think people have only even more recently gotten familiar with, is the story of Henrietta Lacks. So Henrietta Lacks was an African-American woman who had cancer in the early 1950s, ironically at Hopkins, was being treated at Hopkins. And during that time, she had a biopsy of her cancer cells. And what some of her physicians/researchers did was they took these cells and they grew them out in culture, and they replicated really quickly. And they found that, you know, in essence, these became immortal cells, like they never died, and they kept replicating. And they secretly took these cancer cells. They never told her that's what these cells were being used for. And these cells go on to be the HeLa cells, the ones that we talk about all the time in biomedical sciences, that have been used in so much research. So just one classic example of how the HeLa cells have been used is they were actually used by Linus Pauling to develop the polio vaccine. So just one clear example. And what's fascinating about this story is that for decades, it was really hidden that these cells came from Henrietta Lacks. And some of the scientists who were involved in actually doing this, they actually would change the name and try to make it harder for people to find out that this is where the cells came, because again, they did not get consent for it. And so these cells are all over the world now, been used all over the world and been used to create so many vaccines and different medications to, you know, help with cancer, other conditions as well. To this day, the HeLa cells are pretty important. And so when you think of just the history of it, it's just, to me, again, it's just fascinating. But again, this primary example of racism in medicine, where this Black woman's cells were used, basically become this source of so much research and actually money to a lot of researchers over the last, however, but now 60 years and still going. But her family didn't even find out till the 1970s. So how do we address racism in healthcare? So I'd say first, we all take a deep breath, because it's a lot of work. So I think from a policy standpoint, from a societal standpoint, it's really trying to do the good work of thinking about all the institutional racism or structural racism, as another term that people use, and trying to dismantle those policies, because these are the policies that drive social determinants of health that are experienced by communities of color. So sometimes I feel like we lose sense of our discussion, because when we say social determinants of health, it feels like racism is taken out of that context. But if you actually look at a lot of the social determinants of health, racism is actually a precursor to a lot of those social determinants of health. When we think about the places where people live, how they live, the built environment, all of that, some of that is actually propagated and, you know, influenced heavily by racism. So it really requires us looking at a lot of what exists in society in terms of our policies and trying to change them. The second thing is just really supporting policies that have a positive impact on where children live. And then just changing the healthcare system and research practices that perpetuate inequities. So again, looking back at the Tuskegee experiments, HeLa cells, the Flexner report, just figuring out ways we don't do those things again. Think about our research practices, how we categorize race, ethnicity, and report it in our studies, in our research, and making the healthcare system, you know, a much more friendlier place for all different groups, and making sure that quality that's reflected in the healthcare system is quality that's important to all our diverse groups of patients. You know, other things people talk about is revamping medical education. So doing a lot more implicit bias training early on, incorporating a lot more social determinants of health and medical education. I think that's also important. I think now in the last few years, people are talking about more and more about adopting an anti-racism framework or approach, that we all sort of take this much more proactive response in dealing with racism. So not being passive, not just saying, oh, it doesn't exist in our institution for whatever reason, we're really diverse, or we're not diverse, so it doesn't even matter here. It's saying, you know, I'm not going to take that passive stance anymore. I'm really going to be proactive in how I think about it. And then the other thing that you've seen in the last probably a few months is this concept of declaring racism a public health crisis. So we've seen cities and counties do it. And it's not that it comes with any resource. It's really sort of a commitment to looking at racism in a different way, to say that this is a public health crisis. These are all the downstream effects, and this is what we're going to do about it. So again, this is not an exhaustive list. And, you know, if it was this easy, things would be done. And so it's something, just a framework of thinking about what we need to do. So just transitioning a little bit for the last part of this talk is, a lot of times in these discussions about racism, about bias, around health inequities, people say, well, one way to really address it is really just to, you know, increase the diversity in healthcare. And I agree that's really important. And here's a definition of diversity by the AAMC. And it's really being mindful of socioeconomic status, race, ethnicity, language, nationality, sex, gender, sexual orientation, disability, which is something that, again, doesn't get a lot of attention, geography, and all these other areas. And so there are all these benefits of diversity in healthcare. So there's data that actually shows that it improves the learner satisfaction, educational experience, that diverse teams are able to solve complex problems much more easily because of all the perspectives that come into place. That if you have diverse providers, they may increase access in underserved communities, and that when you have diverse researchers, they ask fundamentally different questions and more complex questions based on their background. So here are all the benefits of diversity in healthcare. And again, the idea is that, well, this could really actually solve the problem. Another rationale for diversity in healthcare is just really consistent with where our population is going in terms of becoming a predominant minority majority. And we see that it's already become that for children, but will become that for adults as well a few decades from now. And so the next thing is actually just looking at what diversity looks like in medical schools in terms of our workforce. So if you look here as US physicians by race ethnicity from 1980 to 2012, you can see that the number of white physicians, male physicians, has gone down a little bit. For female white physicians, gone up. But then if you look at, just focus on Black, African-American, male, women, Hispanic, male, women, Native American, you can see those lines are really just flat. They come up a little bit for Asians, but for African-Americans, Hispanics, they are flat. And the bad news is if you look at specifically at African-American males, the number of African-American males in 2020 is lower than it was in 1978. So it's not just a lack of process, it's actually a regression in progress. And this is just showing different data. This is looking at specifically medical school faculty from 1971 to 2011, and this is from the double AMC. And so it's hard to follow some of these lines because they kind of look kind of crazy with some of them trying to follow the numbers. But again, if you focus on the lines that represent African Americans, Hispanics, those lines are absolutely flat from 1971 to 2011, and not much has changed since 2011. Those lines continue to be flat. So it just shows that despite all of our interventions, all the promotion that we have about diversity pipeline programs, nothing has really changed. So, you know, when we think about diversity in medicine, one thing is just sort of to understand as we start off is what is it defined as? And so, you know, there are larger definitions of diversity, but one that people specifically focus on is underrepresented in medicine. That is defined as racial ethnic populations that are underrepresented in medicine relative to their numbers in the population. So it's African Americans, Hispanics, American Indians, Pacific Islanders, and Native Alaskans. And so, you know, what does normal state or current state look like for these groups in medicine? And what it looks like is something that is colloquially called the minority tax, in the sense that these groups, underrepresented groups, also oftentimes take on the burden of trying to create diversity within their institutions. So, you know, once they're hired, whether it's implicit or explicit, there's this pressure to really represent their otherness within the institution for the good of the community. So it's, you know, being on all these committees, doing all this work, and oftentimes it's at the expense of the individuals. So if they're a researcher, they're not spending time doing that. They're doing these committees, they're doing pipeline programs. And the problem is that because there's so few of these individuals at any institution, that's just a few of these people doing all the work. And so what does the minority tax look like? It looks like service on committees as the minority representative, you know, organizing all these diversity events, you know, being the leads for recruitment initiatives for underrepresented minorities or underrepresented medicine, mentorship and pipeline programs for underrepresented medicine groups, leadership in community projects. And then at the same time, while you're doing all that work, that individual may be combating racism and microaggressions in clinical settings with their colleagues, with patients, with staff. And so that's why it's called the tax. Like, just to be in medicine, this is all the added stuff you have to sort of pay the price of as an underrepresented person. And so some of the negatives about it, if they don't seem apparent already, is that they're frequently time consuming, they're not really well resourced, it's kind of on your own time, it's volunteerism, and they're not taken seriously as promotion earning activities. So the same division head who says, Gene, I really like you to be on this committee, and it takes a lot of, they don't know, it takes a lot of time, a year later may say, Gene, where are your publications? Where are your grants? And you say, but I've been doing this committee, and they'll tell you, no, that's service. What about all these other areas? So again, sometimes we actually contradict ourselves in terms of what we're telling, our faculty, what the goals are for diversity and what's rewarded and supported. And that goes for faculty, that goes for fellows, that goes for residents. And it's not that these underserved groups don't want to do that work. They absolutely want to do this work in some way. It just may not be to the extent that what they're feeling in terms of the tax. And so what does that lead to? So it leads to isolation because there aren't that many people that look like you. It leads to conflict because you feel like you're always the one being put out there to sort of fight these battles. You'll have lower job satisfaction because you may actually not be able to do the work that you came to do at that institution in terms of research, medical education, because you're spending so much time, dealing with your tax. You may not have great scholarly productivity, which is going to affect promotion, career advancement, all of that. And then finally, you'll feel some burnout. So I want to talk just very briefly about this article that I saw that came out in January 2020. It was called Why Black Doctors Like Me Are Leaving Faculty Positions in Academic Medical Centers. And the author, Uche Blackstock, is someone I got to know when I was just finishing medical school, and she was just coming in as a first-year medical student. And so I know her, so it was even more compelling to me to read this and some of what she had to say. So I'll just read a few of the quotes. So one is, I made the difficult decision to leave my faculty position at Academic Medical Center after more than 9 years there because of a toxic and oppressive work environment that instilled in me fear for retaliation for being vocal about racism and sexism within the institution. Even the physical environments of academic medical centers can convey exclusionary messages to students and faculty members. The hallways and auditoria of many such centers have displayed portraits of white men who were accepted into medical schools under racist admission practices, and even some who participated and profited from slavery, colonization, and the oppression of Black people. So again, this is heavy stuff, but this is consistent with the experiences of what a lot of people who are underrepresented in medicine feel like in these institutions. I find it ironic that Black faculty members are unfairly tasked with the complex and overwhelming chore of remedying the structural outcomes of centuries of institutionalized racism that we did not create in the first place. So again, getting to this concept of the minority tax or diversity tax, however you call it. And the last comment, these centers as exemplars of clinical, educational, and research innovation shoulder the responsibility of ending health inequities and creating environments where Black students and faculty members not only survive, but thrive. So here she's sort of pushing back and saying, it shouldn't be on us as individuals, it should be on the institutions as a whole. So in thinking about the diversity in academic medicine, I think there's, things that we could do at the individual level and the institutional level. So at the individual level, I think it's really trying to support, your underrepresented faculty, med students, trainees in terms of having not all the responsibility be on them to do diversity work, and for those individuals to participate in activities that are most meaningful to you. So if you want to do research, do your research, thrive in your research, excel in your research. If you want to do some of these diversity activities, do the ones that are most meaningful to you and really try to find a way, if possible, to align that work with your scholarly activities. So I think those are the things to do at the level of the individual. At the level of the institution, it's about leadership. It's about the highest level of the organization promoting diversity and making it responsibility of all individuals, and not just saying, I will task these 7 people within my institution with addressing diversity for the whole institution, which actually just face value doesn't make sense. And I think we have to think about assigning some promotional value to diversity efforts. And I think something that's really important is really acknowledging the work that people do around diversity efforts, because people do this work with not a lot of resources, with not a lot of fanfare, and oftentimes it's not even acknowledged. And to whatever extent we can is really to fund in diversity efforts, to really give some resources behind them. I think another thing is really, again, along the lines of leadership, is really mentorship for those individuals who are underrepresented in medicine, but also sponsorship, which is a much more active and engaged version of really providing opportunity. And I think the last part of it is just really fostering leadership opportunities for UIM as well. So in conclusion, the root causes of health inequities are complex, and oftentimes we think about it in that social determinants of health framework. But I think And I hope that we're starting to see now over the last few months in our current events that, there's just impact of bias, racism that truly is undeniable. And I think for us today, the goal for me was just to sort of go through some of the data and what we know, how to think about it. And I don't want to provide you with complete answers today. I don't have them actually, but I want to produce, a cascade of questions for you all and further discourse that we can all have together or in our smaller groups, that even in Maine, that we still think about these topics. So thank you very much.
Thank you so much, Dr. Raphael, for a very engaging and very thought-provoking talk. I think you've given us a lot of information to think about. And I wish we had more time for questions. I think I would encourage people to send their questions in through the chat. And Dr. Raphael, would you be amendable if we sent you the questions via email to respond to?
Absolutely, absolutely. And I know I'm sorry because there was so much to cover, but I'm happy to take all the questions and then answer them and then send them your way, and then you could send them out to everybody.
Thank you so much. One question that did come up that's a quick answer was the data about African-American patients selecting lower quality hospitals based on a national sample, or was that from Maine?
It was a national sample.
Okay, that's what I thought. Well, thank you so much for taking the time. I know you spent a lot of time looking at the data specifically from Maine to help us get a better understanding of what we can do here. And thanks again for sharing your expertise with us.
Thank you so much.